Good morning or afternoon, everyone, and thank you for joining us for today's session. My name is Kristen Reed, and I am a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. Today we will be discussing mindfulness-based interventions on maternal perinatal mental health outcomes. Our presenter today is Dr. Angus MacBeth, lecturer in clinical psychology and Honorary Principal Clinical Psychologist in the Department of Clinical and Health Psychology, School of Health and Social Science at the University of Edinburgh. Welcome, and thank you for joining us today. We would also like to wish a warm welcome to all of our health evidence users that have joined us for this webinar. So throughout the session today, we will be posting polling questions through the WebEx platform. We'd like to let you know that your participation in polling questions is voluntary and anonymous. So I will just leave this slide up for a moment and then move on shortly to give you a chance to read it. So just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within about a week or so. And the links to both of these resources will be posted in the chat section now. So today we are very excited to be talking about the review, The Effectiveness of Mindfulness-Based Interventions on Maternal and Perinatal Mental Health Outcomes, a Systematic Review. The link to the Health Evidence Review page for this systematic review will be posted in the chat section. You can click on the link and follow along in the review using the article full text or PubMed link out. We will also post the direct link to the full text article in the chat box so you can access it. So just a couple housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host to make sure everybody is able to see it. Also, please feel free to post your questions and comments throughout the session. Towards the end of the session, we will save some time for the presenter to respond to any of the comments or questions that you might have. For the best connection, we do recommend that you use a wired internet connection versus a wireless. And should you have any connection issues, we have posted the 24/7 WebEx helpline on this slide, as well as in the chat section. For your audio today, please listen through your speakers. If you are having trouble hearing, you can go to Communicate at the top bar in WebEx and then click Audio Broadcast or call the WebEx helpline. So we have our first polling question of the day. And this can be found on the right-hand side of the WebEx platform. And really, we're just trying to get a sense of how many people are joining us today. So if you could please fill out the polling question there, and please make sure to press Submit at the bottom after you have selected your response so that it can be recorded. So we have quite a few answers coming in. Most people are joining by themselves, but there are several groups of 2 to 3, 4 to 5, and actually a couple of 6 to 10 as well. So that's really great to see. So I'll move on, but I'll leave that polling question open for a bit, and then we can continue on. So we would also like to give a very big special thanks to our health evidence team who have worked to bring us this session to you today. There is a large team of us who work to keep health evidence current and maintained, as well as to coordinate our monthly webinar series. For those of you who may not be familiar with Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 5,000 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of Health Evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So the value add for using Health Evidence is that we save you time. We've done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health practice and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. So we've done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. So I'm just going to quickly touch on the model for evidence-informed decision-making before we begin, and we can keep this in mind as the presenter goes through their systematic review today. So this model consists of 5 components that you can see in this diagram. So traditionally, public health practitioners and decision-makers consider evidence about community health issues and local context, existing resources that are available, community and political climate in making decisions about programs and policies. However, it has become apparent that considering evidence about research can be challenging to integrate into public health practice. So as such, the Health Evidence webinar series is really designed to highlight research evidence relevant to public health decisions. On this next slide, we can see the stages of evidence-informed public health that illustrates the steps involved in evidence-informed practice. The wheel is really a guide for practitioners and decision-makers to determine how to address a particular issue by systematically incorporating research evidence into this decision-making process. There are 7 steps outlined here, and today we will be focusing on how the presenter has worked through the first 4 of these steps in order to help public health decision-makers with the remainder of the steps in this process. So we have our second polling question right now, and really we were just wondering how many participants here today have heard of or are familiar with PCOS. So thank you for answering. We do have quite a few answers coming in, and overall, about 40% of people actually haven't heard of PCOS, and about 30% have. So for those of you who are unfamiliar, PCOS is a way for you to actually structure your research questions. So it involves defining who the population is that you're interested in, what the intervention, program, or service is that you want to know about, the comparison group, if there is any, and outlines the specific outcomes you are looking for. So sometimes also we do have a particular setting in mind that we can also state in this format. So for example, in a school or community setting. So the value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which then allows you to further articulate specific components of the question and can help you search for relevant information related to your PICO more easily and efficiently. So moving on to our next polling question and our last polling question before we get started with the presentation. We're wondering how often do you use systematic reviews to inform programs or services that you are involved with or delivering? Do you use them always, often, sometimes, never, or perhaps you're not quite familiar with what a systematic review is? So we have several coming in and several responses coming in, and overall, I think most people say that they often or sometimes use systematic reviews. So that's really great. So without further ado, I will move on to introducing our presenter for today. We are really excited to have Dr. Angus MacBeth with us today to present his systematic review. So I'll pass it along to Angus, and thank you very much for joining us today.
Good morning and good afternoon. Hello. From Scotland, I'm Angus MacBeth, and Thank you to Kirsten and the Health Evidence team for that introduction, but also for the opportunity to present to this audience today. So I'm really excited to be sharing the results of our recent systematic review of mindfulness and perinatal mental health. In terms of a bit of background about myself, I'm an academic clinical psychologist and practicing clinical psychologist in the health service in Scotland, and I have a particular interest in the development both of evidence-based interventions and frameworks, but in particular in perinatal mental health, from complex mental health problems right down to a sort of more public health general population setting. So I'll move on to the slides now. The review that I'm going to present today, much of it was conducted by one of my master's students, Shi Z, so it's a joint effort in terms of the scholarship that's gone into the presentation. So our start point is pregnancy and mental health. And as I'm sure most of you are aware, pregnancy and the perinatal period, so the point from conception through to sort of roughly 12 months postnatally, is a period of rapid and significant change in a woman's life, but also in the broader partners, family and support system, but particularly encompassing a number of biological, social and psychological changes. So as a clinical psychologist, I'm particularly interested in those psychological changes and the impact of mental health and mental well-being on the pregnancy pathway. And what we already know from sort of general population estimates is that anxiety and depression are relatively common within the population during pregnancy. So perinatal anxiety affects approximately 10% of all pregnant women. And in anxiety, there's a distinction between anxiety relating to the pregnancy itself, which tends to have a sort of peak in the first trimester around the viability of a pregnancy, and then again in the third trimester as labour approaches, and contrasting that with trait anxiety, which is a more stable sort of psychiatric profile of anxiety. Accompanying that, we have depression, dividing into postnatal and antenatal depression. Antenatal depression estimates vary, but up to around 20% of pregnant women experience some level of low mood. And of course, postnatal depression, which is a sort of understandable public health concern, impacting on approximately 12 to 16% of women. In terms of our theoretical position, there's a number of impacts in terms of perinatal mental health. There's the influence of the parent or the mother-to-be, in this case, their own mental state, both during pregnancy and postnatally, impacting postnatally on the development of the relationship with the infant. But also, increasingly, we understand that mental health during pregnancy has a number of sort of biological effects, particularly through cortisol and other sort of biochemistry and hormone changes, which can potentially potentiate offspring outcomes in relation to anxiety and development. In addition, around that sort of labour birth point, we know that there are associations between common mental health difficulties and complex mental health difficulties and a number of adverse outcomes in pregnancy. So from that perspective, the development of effective interventions for reducing anxiety and low mood during pregnancy or increasing well-being has a potential positive impact both on the mother-to-be and ultimately on the infant. Given the understanding of potential side effect profiles in psychotropic medication, there's also scope for the development of evidence-based psychological interventions as an alternative or an adjunct to medication strategies with potentially a lower side effect profile. So from that perspective, there are a number of psychological interventions in pregnancy that have been developed and evaluated, but in particular I want to focus in today on mindfulness-based interventions, which are of course in vogue, and we know that if you go onto the App Store or equivalent, there are any number of mindfulness-based apps that you can download to improve your well-being at all times of day and night. If we come back to the definition of mindfulness-based interventions, really these stem from Jonathan Kabat-Zinn's definition of mindfulness as a way of paying attention in a particular way, on purpose, in the present moment, and non-judgmental. So focus particularly on the present. Derived from more Buddhist Eastern philosophies, but translated into a sort of North American and European idiom. So mindfulness includes a sort of acceptance of situations and relationships as they are, and can be tagged onto a more compassionate, open-minded approach. And the mechanism by which mindfulness-based interventions operate is to encourage this non-judgmental, here and now focus that then impacts on well-being via reduction in anxiety and fear. The number of evidence-based reviews in the adult mental health literature suggesting robust, at least moderate effect sizes of mindfulness-based interventions on anxiety, and also in the reduction of low mood or increased well-being for all participants, particularly in terms of the effectiveness of mindfulness. We see strong, robust effects for those with pre-existing anxiety and mood disorders, and that's perhaps important when we look at the evidence base of mindfulness as applied to interventions during pregnancy. One of the difficulties with mindfulness, and perhaps the function of its popularity as a psychological intervention, is mindfulness has become a catch-all for a number of different approaches and strands of psychological intervention with a greater or lesser evidence base. So when we set out to complete this review, we looked at definitions of mindfulness which really cover more sort of diffuse or vague definitions of just purely mindfulness or mindfulness techniques or approaches, to more manualized approaches that would be akin to what we'd see in general adult mental health. And in particular, that would be mindfulness-based interventions and treatments, mindfulness-based stress reduction, which is the original Kabat-Zinn approach, focusing very much on that here and now focus and guided meditation, or something like mindfulness-based cognitive therapy, developed by Kabat-Zinn, Siegel, and Williams, which takes the MBSR components and bolts on more mainstream cognitive behavioural therapy approaches to generate a hybrid approach. And MBCT, we know, has a strong evidence base in the prevention of recurrence of depression. In addition to these manualized therapies and these mindfulness-based treatments, we also, and I think this is a unique facet of the review we've completed, we looked at the boundary between mindfulness and yoga, building in mindful yoga and mindful meditation. I'll come back to that in a minute. So as we consider the mindfulness literature, we also looked at the impact of yoga in pregnancy. And in particular here, we were looking at more integrated yoga as opposed to physical exercise-based yoga. We know that yoga, when it's integrated with meditation-type practices, has an impact on improving maternal physical health in pregnancy, and therefore improving labour and birth outcomes. There is a paper by Nguyen et al. That recognises that yoga practice in pregnancy potentially impacts on anxiety and depression. and therefore potentially on labour and birth outcomes via reduction in anxiety and depression. And in our conceptualization, we noted this overlap in these integrated yoga approaches with the types of active components of mindfulness-based interventions, particularly around meditation, breathing regulation, relaxation, and again, this focus on here and now. So in completing our review, we chose to incorporate yoga interventions if they followed a number of criteria, which I'll come to in the methodology section. Now, one of the themes, as I say, is the popularity of mindfulness, and indeed in the process of completing this review and taking it through the peer review process, it is now one of 4 recent reviews in the last 18 months or so of the impact of mindfulness-based interventions, or MBIs, in pregnancy. Where I think we differ from the other 3 papers is we took a systematic review approach as opposed to a meta-analytic approach, and that potentially has some impact in terms of the nuances of our findings. I think our findings are consistent with the other recent reviews, but pose a number of challenges around the interpretation and the methodology of the results. So in our review, we sought to systematically review the evidence base for the effectiveness of MBIs, particularly focusing on MBCT, MBSR-based approaches and mindfulness-informed yoga. And our interest was in the impact of these interventions on common mental health difficulties, specifically anxiety, depression, and stress during pregnancy. As you'll see, the definition of outcome becomes slightly limited in our review due to the evidence, or the state of the evidence. And in our review, we focused on narrative synthesis using a PRISMA approach, but for narrative rather than meta-analytic synthesis, to try and address the theoretical and methodological challenges in the current literature, the differences in method, and give some clear outcomes and interpretation to further the field. So as I said, into the methodology, we had a PRISMA review. We set our search limits from 1980 to the end of September 2016. As you'll see, that there was a relatively long review process. So when we compare this to one of the more recent reviews, we'll see a number of papers have subsequently been published in this area. In terms of yoga interventions, we included these only where there was clear evidence from the intervention description of a number of components that were consistent with an integrated mindfulness practice. So we could be confident that although the intervention was yoga intervention, that there was sufficient overlap in the components. This sort of focus on non-judgmental focus on sensation and in terms of body scan, relaxation, breathing, and so on and so forth. So in terms of papers where there was simply a description of a sample of women in pregnancy being exposed to yoga, that was not sufficient per se to meet our inclusion criteria. And speaking of inclusion criteria, we place no limits on whether it was the first pregnancy or sampling from multiple pregnancies. We did require some form of measurement of depression or anxiety, either via validated self-report or interview measure of depression, anxiety, or common mental health phenomena, or meeting diagnostic criteria for depressive or anxiety disorder. We required some form of assessment during pregnancy or during the first year post-delivery with women aged between 16, or mean age rather, between 16 and 45 years of age. And because we didn't opt for a meta-analytic approach, we were able to include MBI either in comparison with a control group or without a control group. So we were able to incorporate within subjects evaluations of the treatment. We looked to include studies that had a treatment component which either used some form of manualized protocol, such as the MBCT protocol or MBSR, accredited facilitators or delivery by a health professional where we could clearly identify that there was specific training related to mindfulness-based interventions. In terms of our exclusion criteria, we excluded studies where participants had a current psychosis or complex mental health disorder, where the depressive or anxiety symptoms were comorbid to specific physical disorders. We excluded those studies. We also a priori excluded studies where there were medically defined high-risk pregnancies, particularly multiple pregnancies, due to the position of these as being a high-risk pregnancy and differentiated from our sort of general pregnancy samples. We also excluded qualitative studies, case studies, book chapters, and the existing reviews. In terms of our evidence synthesis, although we opted for a narrative synthesis, we did estimate effect sizes. So I'll make some reference to these in the results. So draw your attention to the Cohen's d conventions, where anything below 0.2 is really not worth reporting as an effect, a trivial effect size. So really we're looking at small to large effects here, small being 0.2 to 0.5, moderate 0.5, large anything above 0.8. And in terms of psychological interventions, we know that the majority of psychological interventions where effective are really coming in at around a moderate effect size. In addition, we wanted to look at the potential sources of methodological bias in our included studies, and to do that we used the Cochrane risk of bias tool to enable us to rapidly compare between studies. So in terms of our Prisma flow, if you follow that down, you can see our exclusion criteria, and of course all of this is available in the published paper, but what you see is we ended with 17 studies representing 18 cohorts. In terms of the designs, we had 7 RCTs, so randomized control trials, 2 non-randomized trials, so a comparison of an MBI with some other intervention, but not with random allocation, and 9 non-controlled evaluations. So these would be our within subjects pre-post evaluations of the impact of mindfulness. We reported a total sample of 640 participants, of which 603 were adjudged to be completers of treatment. As you can see, the majority of studies conducted in the United States of America, and a small minority of studies in Australia, and I believe the other studies, certainly one in Iran, and I forget the other location. In terms of types of intervention, we see MBCT, that mindfulness-based cognitive therapy, in 7 of the studies, MBSR in 9 studies, that's the Kabat-Zinn stress reduction approach, mindful yoga in 1 study, and prenatal yoga that was adjudged to be sufficiently detailed to constitute mindfulness-based approach in 1 study. The mean number of sessions, approximately 8 weeks, ranging from about 6 to 10 weeks. This would be typical for a mindfulness-based protocol. Approximately 2 hours per session. What we didn't identify was the breakdown in terms of what trimester the interventions were delivered in, but as you can estimate, an 8-week treatment protocol would probably require majority of treatment in 2nd trimester, perhaps into 3rd trimester. One of our key findings actually is engagement in mindfulness-based approaches was particularly high. There was better dropout in terms of the trials in our mindfulness-based arms and studies compared to the control groups, with the exception of 2 studies, Zhang and Emery, which was a sample of high risk, apologies, there's a siren going off in the background, a high risk African American sample from the US with low income and difficulties in engagement. The other study where there were dropout issues, the Felder study in 2016, which used an online delivery, online-only format delivery of mindfulness-based techniques. Okay, so in terms of the effectiveness of the intervention, and that's really the crucial aspect for an evidence synthesis, with regard to depression, if we looked at our randomized control trials and our non-randomized trials, 3 studies showing significant reductions, most in the sort of small to moderate, hedging towards moderate effect size. Most of those studies were NBCT protocols. 2 studies demonstrating trend level of change, so not statistically significant, but suggesting an effect of mindfulness on reduced depression symptoms post-treatment, but not hitting that statistical significance, and 1 reporting a null result. In terms of the open trials, these would be the non-randomized trials, you would see 8 showing significant improvement with quite a range of effect sizes from small all the way up to very large effects. So this is a sort of hallmark of the trials literature that within subject studies you get much more variability in terms of the treatment effect due to the lack of a control group. With regard to anxiety, 7 studies from the RCTs and non-randomized control trials, a slightly more consistent impact of mindfulness on anxiety. 5 studies showing significant reductions, should be mostly moderate to large effect sizes. When in those studies where they drilled down into the type of anxiety, in the case of pregnancy-specific anxiety, there was no significant evidence for mindfulness impacting on pregnancy-specific anxiety. In terms of the anxiety open trials, these would be the trials without control groups, slightly fewer studies, quite a number of non-significant results, and again quite a lot of inconsistency in the effect. Moving on to stress, we also incorporated consideration of a more sort of diffuse stress outcome. Results relatively equivocal. 1 study reporting a significant effect, 1 reporting clinical improvement, although not statistically significant, but really much more equivocal findings for stress as an outcome. This may be a function of stress being itself a more generalized measure of well-being and mental health, and thus open to much more variance in terms of definition and interpretation. Similarly, in our open trials, very equivocal effects. However, that said, when we looked within the RCTs, just within the RCT, the mindfulness arms of our RCTs, we got relatively large pre-post effects on stress. So what it may be that this diffuse nature of stress measures suggests that there are large effects of mindfulness itself, but they are washed out in a treatment comparison, because you also see just a sort of natural effect on stress of just progressing through pregnancy, and stress reducing in the control group at similar rates to the stress reduction via an intervention. So effectively you get a washout in the comparison. In addition, we also looked at the mechanism of change. So we're interested in whether participation, is the degree of tautologicalness in this, that whether participation in a mindfulness-based intervention changes one's approach to mindfulness and increases one's capacity to be sort of open and non-judgmental. And what we noted from the studies pulling across the RCTs, the NCTs and the open trials, is actually quite a consistent, significant effect for changes in mindfulness pre to post in the mindfulness arms versus the control arms. 5 RCTs reporting a significant change, 1 non-controlled trial suggesting a positive non-significant trend, and 5 out of 6 of the open trials suggesting change, but with variations in the magnitude of effect. And all studies here were using the 5-facet mindfulness questionnaire, which is a sort of industry standard measure of changes in mindfulness. Now, this, on one level, this is a not entirely surprising finding that participation in a group on mindfulness increases one's knowledge and awareness of mindfulness, but it's worth bearing in mind in terms of the potential for sleeper effects, whereby although we don't necessarily see a consistent effect on psychopathology symptoms or mood and anxiety symptoms, that there is a change in the psychological mindedness of participants in mindfulness-based interventions. Moving on to the method of bias. This is our method of bias table, and what we see here down the left column is the individual studies, and then a number of methodological criteria that Cochrane set in terms of potential key components of a rigorous intervention or a rigorous evaluation of intervention. So the selection bias is around the randomization process, and obviously for a number of our studies this is not applicable. Then performance bias is mainly around the blinding of assessors and participants to the treatment arm. Then psychological interventions, being blind to treatment arm, is rather difficult, particularly where the treatment is clearly around sort of focusing on a particular psychological intervention. So it's unsurprising that there's a lack of clarity across the board in those studies. Then we have factors on outcome assessment, and also dropout, and then the analysis and the reporting. Now, what it's worth focusing in on this is we looked at the qualitative differences in terms of how consistently covered these factors were, but we also ascribed a nominal score for methodological biases out of 10, where 10 would be very low risk of methodological bias. It's worth noting that the majority of our studies were not without methodological difficulties, and that's not to say that the studies weren't meaningful or of importance to the field, but I think that really is a representation of the relative infancy of evaluations of mindfulness in the perinatal period. I think the oldest trial we were able to identify, our oldest study we were able to identify, was 2008. So we are looking at less than 10 years worth of trials data. And as I said, while we were going through the peer review process, there were a number of additional publications and reviews. The most recent one is the Dillon meta-analysis. It's worth just looking at this as a comparison to I suppose from a methodological point of view, look at the different ways that evidence synthesis can be approached. Dillon's review was only of controlled trials. So we see overlap in sort of 9 of our studies. We had an additional 8 studies which are our non-controlled trials, so giving us information on just treatment effects pre-post. And finally the Dillon papers, the 4 additional papers, they identify 1 which didn't meet our criteria, and the other 3 are subsequent publications. And my understanding would be if you repeat the Google Scholar search on recent publications on mindfulness and pregnancy, you'll find a number of further trials subsequent even to publication in the last 6 months. So I think one of the important take-homes here is it's a very quickly evolving field. So just to take you towards the conclusion of my talk, in terms of the take-home message, we do have some evidence of effectiveness of mindfulness-based interventions during pregnancy on common mental health difficulties, particularly reductions in depression, reductions in anxiety. However, the effect sizes are somewhat inconsistent and at times wash out in comparison to control interventions. So there's a number of interpretations here. I think that this gets us into some of the issues with trials, but also in trying to focus in on mental health during pregnancy. So in terms of the methodology of the included studies, we generally had a relatively well-educated, knowledgeable recruitment in terms of the participants. So where mindfulness-based interventions were less impactful were in existing mental health samples or in sort of low-income, increased vulnerability samples. So there is perhaps a inherent bias in the recruitment of participants to these types of trials. In addition, much of the recruitment, therefore, was from general population, sort of community sampling or sort of university hospital routes. And what we potentially saw there was a floor effect, that actually the rates of depression and anxiety are relatively low prior to randomization and recruitment to studies. So therefore you have a floor effect, that there's simply not much scope for manoeuvring the effect size down as a function of treatment compared to control. So one possibility is whether mindfulness-based interventions may benefit from being targeted to particular subgroups, whereas a more generalized, perhaps web-driven platform for general population may be sufficient. We should also note some difficulties in the measurement of outcome. Most of our outcomes were via self-report measures of depressive or anxiety phenomena, which may or may not be adapted to pregnancy. So not all studies used the Edinburgh Postnatal Depression Scale, which we would think of as the sort of, again, the industry standard for measurement of mood in pregnancy. So that heterogeneity of measurement and perhaps not having pregnancy-adapted measures of mood could in itself impact on the measurement of the outcome, which then, of course, biases the interpretation of the measurement of the effect. In terms of the mechanisms of change, we did see a very consistent message that mindfulness impacted the mindfulness-based interventions rather impacted on participants in terms of changes in mindfulness, and that may give us some insight into potential mechanisms of change, and also leads us to thinking about where mindfulness-based interventions sit within our kit bag of psychological interventions. So in particular, we noticed that there were effects of MBCT in particular on depression, and of course MBCT was designed originally for relapse prevention in depression and to prevent recurrence of depression. So when we introduced it as a potential intervention for mood in pregnancy, it may or may not be, in terms of the trials literature, be being delivered to a previously depressed sample or a currently depressed sample. So there may be the need to stratify MBCT-based mindfulness approaches into these sort of pre-existing depression or high risk of depression or high risk of postnatal depression type needs matching. In anxiety, again, we seem to have some evidence of an effect, and the potential for mindfulness impacting on anxiety has two potential routes. In terms of the mindfulness-based approach to the sort of here and now and the present focus, that may potentially impact on the cognitive construction of anxiety, sort of anxiogenic cognitions and worries and beliefs about the impact of anxiety, so that refocusing to the present moment may therefore impact to alleviate anxiety. Equally, the emphasis on breathing and deep relaxation may potentially impact on anxiety via reduced physiological arousal. And I think the literature doesn't give a clear signal on how mindfulness may be impacting, so potentially dismantling studies in the future could help us establish by which route mindfulness impacts on anxiety. A number of further methodological limitations actually for 17 to 18 individual studies, a sample size of approximately 600 completers, relatively small sampling. So it may be that simply this literature is still in its infancy. It's too early to make a really clear evidence-based judgment. And I think that is definitely picked up in the more recent meta-analyses. As I've said, lots of treatment heterogeneity and sampling differences and measurement issues. So it may well be that although there is promising evidence of an effect, that we simply need further trials. What I think is striking is that the dropout rates were low and the acceptability of the intervention is high. So as a psychological intervention for well-being in pregnancy, mindfulness is well tolerated by participants, and therefore does have more than a degree of face validity as an accepted option for improving well-being. And in terms of the implications of our findings, I think that there is a debate to be had around targeting mindfulness in pregnancy as a targeted treatment, perhaps for existing high levels of anxiety or existing history of common mental health difficulties or risk of depression. So either targeting the treatment versus a sort of universal provision. I think that the evidence potentially for this sort of facilitated delivery of mindfulness as a universal provision that may not be the most optimal delivery mechanism, and we may need to look towards app-based or web-based delivery as potentially a more effective approach to delivering mindfulness treatments in pregnancy. In addition, in terms of outcome, there's further reporting of this in the paper, but we didn't find much in terms of reporting of outcomes at follow-up. And of course that becomes crucial, because if we think of mindfulness impacting on both maternal sort of psychological well-being, but also maternal physical health via reduced physiological arousal, we would potentially see some effect impacting on the infant via physical outcomes or labour-related outcomes, and we simply just didn't see much in the way of reporting of these outcomes. But also we don't know whether the teaching of these mindfulness practices during pregnancy has a sleeper effect in terms of improving sort of stress regulation in terms of mother-infant interaction, and that's really an area that would be very exciting to potentially follow up on in future. And the other methodological implications, of course, that we need to have just greater methodological rigour in the trials of these interventions. And I think we see that emerging in the trials that have been published in the last year or so. And we would expect that there's a very clear signal coming from our own review, but also the other recently published reviews, that methodological rigour really is crucial to the evaluation of this area. So with that, I think the take-home is there's a promising evidence of the effectiveness of mindfulness, but as yet we still need more evidence to be able to make a really clear evidence-based judgment on how we roll this out into treatment settings. So with that, thank you, and I'll hand you back to your host.
Thank you so much, Angus. That was a really great presentation. It was really interesting to hear about what you found. We really do appreciate you sharing this very detailed walkthrough with us today. So we do have a few questions coming in, and I'll be reading them aloud. Our first question is that from our participant is that we understand that antenatal is basically prenatal. However, early on in the presentation, you listed antenatal separately. So what is the difference, would you say, between those two terms?
Okay, so thanks. So the difference between antenatal and prenatal, I think that may be one of these other tricky differences in terminology. I think prenatal, yeah, these are synonyms basically, between prenatal meaning before birth, so similar to antenatal, but I think that is just a bit of slippery wording within the literature. So apologies for that lack of clarity.
Thank you. So the next question we have is, was there any difference in efficacy based on age of participants? So, for example, were these interventions less effective for mothers under the age of 20 years?
That's a really interesting question. I think the difference is difficulty is the heterogeneity in the studies really obscures any sort of ability to get a clear effect on that. Just looking at my notes here, there was only one study that we identified that involved pregnant adolescents who were less than 20 years old. What I would suspect, thinking about the effectiveness of the interventions over the piece, is where you have additional vulnerabilities, you tend to get a lower effect or more difficulties in evaluating the therapy. So my sense is the literature suggests that there isn't yet an effect, that it's not effective in under sort of younger mothers. Now that's not to say that it's not effective because it's not effective. It's not effective, I think, because you potentially need to adapt the protocol and perhaps be more assertive in the delivery and the delivery mechanism of the treatment. But it's a really interesting area, and we know that sort of teenage pregnancy sort of is a sort of high-risk pregnancy, and it's definitely worth looking at how we can bolster psychological interventions in that area.
That's really interesting. Thank you. And I guess, as you said, it is a very quickly evolving field. So hopefully we'll hear a little bit more about maybe some of those subgroups in the near future.
Indeed, yes.
Another question was, you did mention at the beginning of the presentation about, well, and I think at the end as well, about the potential as well as the ubiquity of kind of mindfulness-based apps that are available. And web-based, I guess, if those could be grouped together. But do you know of any studies that are available on this kind of specific to app-based interventions for mindfulness?
I'm fairly confident that one of the studies that we identified that had relatively high dropout was the Felder paper, which is an open trial of web-based mindfulness-based cognitive therapy, which does have a number of established names attached to it, I have to say. I believe that group, I think that's perhaps in Colorado, they have subsequently published further work. I confess I haven't quite got up to speed with that, but I would suggest that's a good starting point to look at if you identify the Felder paper and their group's work, but also look at the citations of that paper. That will give you a sense of what's recently been developed. As you say, the field's developing so fast that it's somewhat difficult to keep up.
Yes, that's completely understandable. Thank you for that. I think I did just want to clarify that in terms of earlier, the difference between prenatal and antenatal, I think there was a comment saying that I think the distinction that was made was perinatal and antenatal, not prenatal. Yeah.
Right. Okay. So yes, to an extent, the trickiness in these definitions remains that perinatal, I think, there's a very narrow definition of it relating to ending just, I think, in the sort of month after birth. I think we've used perinatal in a more broader context to sort of look really at the whole pregnancy window to about the sort of 12 months postpartum. That is playing slightly fast and loose with the terminology, but it's not unusual to do that. I think what's important to recognise is within the studies that we identified, they were effectively almost all antenatal studies, and that's really where I think this literature should be targeted at the antenatal period, because you have a window of opportunity, particularly in the second trimester, where the pregnancy is stable and the physical changes are hopefully still manageable enough that you have a window to engage with these treatments.
Thank you. Yes, that's very interesting, and that's very insightful. So I think I'll have one more question, and then we might move on. But please feel free to continue to post your questions in, and we'll try to get to them if we do have some time. So I think the next question is looking at about your comment on the heterogeneity of the measurements that were used in the included studies. Do you have any comments or thoughts or recommendations on those different types of measurements or measurement tools that were used to assess the outcomes of those interventions?
Yeah, I think there's a couple of issues. I think to an extent, we know that the Edinburgh Postnatal Depression Scale is not without flaw. I say this knowing fine well I'm sitting in Edinburgh, but it is the sort of standard measure of depression in pregnancy. So I think if you're looking at depression in a pregnancy-related trial, you need to be using the EPDS or an adapted measure. In terms of anxiety, I think it's much more difficult because we weren't getting anxiety sort of divides into state and trait, but also we have this specific issue of pregnancy-related anxiety, which of course we weren't getting a strong effect from the literature on. In terms of anxiety, something like the state trait anxiety inventory is probably your gold standard. Equally, if time is of an essence and you need a quick measure of both, something like the hospital anxiety and depression scale, the HADS would be another option.
Thank you. That's really great. Thank you so much. Interesting. So I do have a couple more polling questions, so I will move on, and if we do have a bit of time at the end, then we can hopefully get to another question. But I will open this up, and I guess before we wrap up, we'd like to ask whether or not the information that was presented today was helpful for the work that you do. So strongly agree, neutral, disagree, and strongly disagree are the options that are up there. And again, just a reminder to please make sure to press the submit button once you have selected your response. So several answers are coming in, and that's great. And the vast majority say that they agree or strongly agree, so that's good as well. At this point, we would really like to share a few options for ways that you can interact with health evidence moving forward. And so these include visiting our website, registering to receive our monthly tailored registry updates or the monthly newsletter, stay up to date on new research that's coming out, as well as upcoming events. Tell your colleagues about the website and what it has to offer. You can follow us on Twitter using the @healthevidence handle. And then we also encourage your organization to use health evidence to search for review-level evidence to inform program planning and policy decisions, or contact us if you have suggestions for future topics for webinars or to provide feedback on the series. And with that, then, a final polling question, and with these potential actions in mind, we would really like to get your thoughts on what are your next steps after learning about this review-level research on mindfulness-based interventions for maternal perinatal mental health outcomes. So do you plan to access the full text of this systematic review, access the quality assessment that was conducted for this review on healthevidence.org, consider using the evidence in your practice, or tell your colleagues about the evidence that you've learned about today? So thank you for answering. I think a lot of people are going to have some next steps after learning about the review level evidence today. I think just one more quick question. I know we're a bit over time, but I think, Angus, if you do have a chance to perhaps state again some of those measurement tools that you were talking about, I think a couple people would like to get them written down in terms of your recommendations for those different scales.
Sure, and I can post that as a chat sort of link to, and I'm sure you guys can push that out. So it would be the Edinburgh Postnatal Depression Scale, the EPDS, which is your industry standard depression. The State Trait Anxiety Inventory, the STAI, which I think is by Spielberger. And for a combined measure, the Hospital Anxiety and Depression Scale, the HADS, H-A-D-S, should be Zygmunt and Snaith. The HADS is certainly still copyrighted, so it does cost to use, whereas I believe the PDS and the State Trait are both freely available, I think. Certainly the EPDS is.
That's great. Thank you for clarifying. I have a feeling that they might be used in the near future. So that does bring us to the end of our presentation and the end of our time, or just a little bit over. We would like to give a very big thank you to our presenter as well as to our audience today for posting questions and for making this a very engaging and stimulating conversation. One final reminder that the copy of the recording as well as the PowerPoint presentation will be posted online in the next week or so. You can access that there, and we will also tweet that out at Health Evidence. So thank you, everyone, for joining us. And Angus, do you have any final words?
Nothing other than thank you very much for the opportunity to present this. I'm glad it was of benefit, and I do hope it will influence practice and have a great day. Thanks.
That's wonderful. Thank you very much, and good afternoon to you, I think it is, and thank everyone for joining us today.